Pulmonary vasculitis. Etiology. This is a group of conditions characterized by the presence of antineutrophil cytoplasmic antibodies, ANCA. These antibodies are split into two types on the basis of the pattern of immunofluorescence. 1C ANCA directed against proteinase 3. 2P ANCA directed against myeloperoxidase. Some ANCA-positive patterns do not fit into either category. Many, but not all, have associated evidence of systemic vasculitis. The exact pathophysiology of vasculitides is unknown, but one current hypothesis is that primed neutrophils release lysosomal enzymes and reactive oxygen species that cause endothelial damage. Vasculitides are classified by size of vessel. Large vessel vasculitis. Temporal arteritis and Takayasu's arteritis cause large vessel vasculitis. These do not generally cause pulmonary disease, except where there is involvement of the thoracic aorta. Medium vessel vasculitis. Churg-Strauss syndrome, polyarteritis nodosa, and Kawasaki's disease cause medium vessel vasculitis. Churg-Strauss syndrome involves both small and medium-sized arteries. Polyarteritis nodosa can involve bronchial arteries. Small vessel vasculitis. Wegener's granulomatosis, Churg-Strauss syndrome and Henoch-Schönlein syndrome, the latter rarely involves the lung, cause small vessel vasculitis. In Wegener's granulomatosis, involvement of the respiratory tract occurs by definition. Wegener's granulomatosis is C-ANCA positive in 90% of patients. P-ANCA has an association with Churg-Strauss syndrome. For practical purposes, the two conditions of greatest relevance to the lung are Wegener's granulomatosis and Churg-Strauss syndrome. Some cases of Churg-Strauss syndrome have been described in patients treated for asthma with leukotriene E antagonists. Opinion is divided as to whether Churg-Strauss syndrome has been caused by these drugs or simply uncovered because of the reduction in steroid dose permitted by their use. Epidemiology. Wegener's granulomatosis, mean age at presentation 41 years. No gender predominance. Median time to diagnosis 5 months. Churg-Strauss syndrome, mean age of onset of asthma is 35 years and of vasculitis is 38 years. Clinical presentation. Wegener's granulomatosis. The majority, 90%, of sufferers present with upper or lower respiratory tract symptoms. 73% of cases involve nasal, sinus or tracheal airways. Respiratory symptoms include 1 cough, in 46%, 2 hemoptysis, in 30%, 3 pleuritis, in 28%. Other presentations are seen. 77% develop glomerulonephritis within 2 years of onset. 52% develop ocular symptoms during their illness, e.g. proptoses. 67% experience arthralgia. Fever is present in 50% during the course of the illness. Skin involvement, mononeuritis multiplex and pericarditis are other recognized features. Churg-Strauss syndrome. This has 3 distinct phases. 1 prodromal phase of asthma/rhinitis. 2 blood and tissue eosinophilia. 3 characterized by systemic vasculitis. In the final phase, cardiac, 48%, and skin, 67%, lesions are characteristic. Glomerulonephritis, mononeuritis, arthropathy, and conjunctivitis are also recognized. Physical signs. These depend on the clinical presentation, see above, but could include the following. Wegener's granulomatosis. Pulmonary signs could include those of consolidation or pleural effusion. Upper airway ulceration may be visible on physical examination. Churg-Strauss syndrome. In the prodromal phase, wheeze and reduced peak flow are evident. Later, skin lesions, erythema, purpura with or without nodules, and signs of cardiac failure can be seen. NB. Consider Churg-Strauss syndrome in patients with asthma whose disease becomes more aggressive and steroid dependent. Investigations. FBC. In Wegener's granulomatosis there may be a normochromic anemia, 73%, with leukocytosis and thrombocytosis. A normochromic anemia may also occur in Churg-Strauss syndrome, but the characteristic abnormality is eosinophilia. The erythrocyte sedimentation rate is usually high in both conditions. Antineutrophil cytoplasmic antibodies. Approximately 90% of patients with Wegener's granulomatosis are C-ANCA positive. Of those with Churg-Strauss syndrome, 48% are P-ANCA positive. Histology. Except in clinically clear-cut cases, histological confirmation of diagnosis is required. However, the yield of diagnostic histology by transbronchial biopsy in patients with Wegener's granulomatosis is low, approximately 10%. Alternative possibilities include biopsy of upper airway lesions, renal biopsy, if there is evidence of nephritis, open lung biopsy. Other investigations. Screening blood tests, renal and liver function tests, antinuclear antibodies, rheumatoid factor, angiotensin-converting enzyme, and autoantibodies. Urine. Look for proteinuria, hematuria, and cellular casts as evidence of renal involvement. CXR. May show pulmonary infiltrates, nodules, hemorrhage or a combination of these abnormalities, in 45% of patients. High-resolution CT scan may be a useful adjunct to diagnosis and for monitoring disease progression. Differential diagnosis. The differential diagnosis depends on the nature of the presenting symptom. The more difficult differential can be of eosinophilia. Where there is significant diagnostic doubt, the case for obtaining biopsy material is strengthened. Treatment. Wegener's granulomatosis, steroids with or without cyclophosphamide with or without plasmapheresis. Septrin may have a role for patients with disease confined to the upper airway. Azathioprine is often used to maintain remission. Churg-Strauss syndrome, steroids with or without cyclophosphamide with or without plasmapheresis. Complications. Wegener's granulomatosis, chronic renal insufficiency, in 42%, of whom 1/4 will require dialysis, hearing loss, in 35%, nasal deformities, in 28%, tracheal stenosis, in 13%, and visual loss, in 8%. Churg-Strauss syndrome, essentially a more benign condition than Wegener's granulomatosis, but myocardial damage and gastrointestinal tract involvement are recognized. Prognosis. Wegener's granulomatosis, 13% mortality. Churg-Strauss syndrome, 11% morbidity in long-term follow-up.